Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about varicella or chickenpox. Definition: varicella or chickenpox is an acute, highly contagious intraepidermal vesicular eruption caused by varicella zoster virus. Clinically, it appears as a generalized vesicular eruption. Varicella, individual red and crusted vesicles in a generalized distribution. Incidence: varicella is predominantly a childhood disease with 90% of cases occurring before the age of 10 years. Investigators estimated that 3.5 to 4 million cases occurred annually in the United States prior to the advent of vaccination. Chickenpox occurs throughout the year, but the incidence peaks sharply in March, April, and May. Varicella vaccine has reduced the incidence of hospitalization greatly since its introduction. History: after a 2 to 3 week incubation period, a 2 to 3 day prodrome of chills, fever, malaise, headache, sore throat, anorexia, and dry cough precedes the onset of the mildly pruritic vesicular eruption. The patient is infectious for approximately 1 week, 1 to 2 days before the rash, and a further 4 to 5 days until the vesicles have become crusted. Physical examination: varicella is a generalized pruritic eruption that is most prominent on the trunk but also involves the head, the extremities, including palms and soles, and the mucous membranes of the mouth and conjunctiva. It is characterized by successive curves or rapidly progressive lesions over an 8 to 12-hour period. The lesions begin as macules, which quickly develop into papules, vesicles, and pustules. Crusting and sometimes necrosis precede healing. Characteristically, all types of lesions are present at the same time. The vesicles are 2 to 3 mm in diameter, occur on an erythematous base, and have a dewdrop on a rose petal appearance. They are often umbilicated and hemorrhagic. Varicella: dewdrop vesicle on a rose petal erythematous base. Differential diagnosis: before its eradication, smallpox, which is characterized by a febrile prodrome, lesions in the same stage of development, and centrifugal distribution, was the most important disease to exclude. The presence of lesions in all stages of varicella helped to differentiate it from smallpox, in which all lesions are in the same stage of development. Disseminated herpes simplex and herpes zoster, Coxsackie virus, echovirus, rickettsial pox, and mpox can produce vesicular eruptions similar to those of varicella. Diagnosing varicella is usually not difficult, but if there is any doubt, PCR and cultures can rule out these other infections. The conclusion of differential diagnosis of varicella or chickenpox include smallpox, disseminated herpes simplex and herpes zoster, Coxsackie virus, echovirus, rickettsial pox, and mpox. Laboratory and biopsy: the diagnosis of varicella is usually obvious. Exam preparation reveals multinucleated giant cells typical of herpes virus infection. Viral cultures, direct fluorescent antibody staining of vesicle smear, biopsy, and serologic studies may also be done to confirm the diagnosis, although usually these are not necessary. Culture of the varicella zoster virus is difficult, therefore direct identification of the virus in vesicle smears by immunofluorescence staining is the preferred test. The biopsy, which is rarely done, reveals an intraepidermal blister with multinucleated giant cells. Varicella in epidermis, bulla, and multinucleated cells is present, and in dermis, perivascular inflammation, we can say. Therapy: treatment for chickenpox is largely symptomatic. Antihistamines and topical agents such as calamine lotion are used to reduce itching. Bathing with colloidal oatmeal can be used for its soothing, cleansing, and anti-inflammatory benefits. Aspirin should be avoided in children because of its association with Raynaud's syndrome. Acyclovir or valacyclovir reduces complications in adults and immunosuppressed children. The use of antivirals in immunologically normal children generally is not indicated unless rare visceral involvement is present, such as visceral pneumonia. Varicella vaccination or Varicella is safe and effective in healthy children and adults, especially in preventing moderately severe and severe cases. Passive immunization with varicella zoster immunoglobulin or VZIG or VZIG is used in high-risk patients. Varicella zoster immunoglobulin is prepared from plasma containing high titers of varicella zoster antibody. It is effective in preventing or modifying varicella infection in immunodeficient patients if it is administered shortly after exposure. Varicella zoster immunoglobulin is not given to patients with active disease. Patients with leukemia or lymphoma, those with congenital or acquired immune deficiency, those receiving immunosuppressive medication, and newborns or mothers who have varicella are candidates for treatment. The conclusion of therapy for varicella: prevention with varicella virus vaccine and varicella zoster immunoglobulin. Initially for symptomatic infection with antihistamines like diphenhydramine 25 to 50 mg QID, elixir 12.5 mg per 5 ml, 5 mg per kg daily in 40-weighted doses, hydroxyzine 10 to 25 mg QID syrup 10 mg per 5 ml, 2 mg per kg daily in 40-weighted doses, oatmeal bath, and calamine lotion. Alternative therapy for adults and severe infection or immunosuppression include acyclovir or valacyclovir. Cause and complications: approximately 100 deaths occurred each year in the United States as a result of varicella before the vaccination was instituted in 1995. The major complications like pneumonia, encephalitis, and hepatitis are disproportionately high in adults, very young children, and immunocompromised individuals. Nowadays, with vaccination, the complications, hospitalizations, and death rates from varicella have dropped significantly. Note, morbidity and mortality rates are greatly increased in immunocompromised patients. Varicella during pregnancy possesses an approximately 10% risk of intrauterine infection of the fetus, resulting in congenital varicella syndrome or neonatal varicella with devastating effects on the child. Pathogenesis: varicella primary infection begins in the nasopharynx. After local replication, viremia ceases in the reticuloendothelial tissue. Secondary viremias cause dissemination to the skin and viscera. Varicella zoster virus then enters a latent phase in the sensory ganglia. Clinical case question: a 6-year-old boy is brought to the clinic with a 2-day history of fever, malaise, and a generalized itchy rash. The rash began on the trunk and rapidly spread to the face and extremities. On examination, there are multiple lesions in different stages of development, including macules, papules, vesicles, and crusted lesions. Some vesicles have a dewdrop on a rose petal appearance. The lesions are more concentrated on the trunk than on the extremities. What is the most likely diagnosis? A. Smallpox. B. Coxsackie virus infection. C. Echovirus infection. D. Rickettsial pox. E. Varicella or chickenpox. According to our explanations, the correct answer can be Varicella or chickenpox. Explanation: Varicella or chickenpox is characterized by lesions in different states simultaneously, centripetal distribution, more on trunk, a classic dewdrop on a rose petal, vesicles is associated pruritus, and mild systemic symptoms. Differential diagnosis: smallpox lesions are in the same stage and have a centrifugal distribution, more on face and extremities. Coxsackie virus typically causes hand, foot, and mouth disease with lesions on palms, soles, and oral because echovirus often causes a non-specific viral exanthems and not vesicular lesions in different stage, and rickettsial pox presents with an eschar at the bite side and a vesicular rash, but distribution and progression differ from varicella. Okay, this was an explanation about varicella or chickenpox. Thank you for your attention.